Rightio. Thanks very much all for dialing in. My name's David Davis. I'm the chairman of the Red Line Group. I'm delighted to welcome you to this, the second in a summer series of Zoom webinars that we've organised in lieu of the information day that we had to cancel because of COVID-19. Very strange times, and I hope you're all keeping well. The details of the webinars are all on the website, pouchsupport.org. With thanks to my colleagues on the Red Line Group Committee, Christopher Brown, who's set up the speakers, and Gary Bronzier, who's actually pressing the buttons for us. Well done, Gary, thank you. I'd like to welcome today's speaker, Janindra WARUSAVITARNE, who is a consultant colorectal surgeon at St Mark's and is an outstanding expert in his field. We've had the a great benefit of his attendance at Information Day, speaking at Information Days in the past. I'm absolutely delighted he could join us today. So thank you for that. Before I hand over to Janindra, just a couple of housekeeping points. If we can have the second slide, please, Gary. This, for those who aren't familiar with Zoom, just a couple of quick pointers. This is the standard screen that you'll see as the presentation is in progress. If you wiggle your pointer on the screen at any point, the black bar will open up across the screen there. You can see about 3/4 of the way down. And it will give you several options. You'll all be muted, so to prevent background noise, as I mentioned. The most important button is the chat button right in the middle. And if you click on the chat button, it'll open up the opportunity for you to ask questions. You can table those questions by typing in under the prompt and pressing return. And those questions will all come into the moderator, which is myself. And at the end of Janindra's talk, he's asked that we keep the questions till the end. As much time as we have, I'll be asking your questions on your behalf to Janindra. So that's the way the questions work. So hopefully you'll all be familiar with that and cope with that. I'd like to pass on to Janindra now. Again, thank you very much in advance for taking the time out to present to us today on the topic of innovations in pouch surgery. Over to you, Janindra.
Thank you. Let me just my thing up. Sorry about this.
Hey, we're seeing you now.
Yep, can you see me now?
Yep, seeing you now, yes.
Cool. Hopefully this will work. Right, so thank you very much to the Red Line Group for actually asking me, and it's something I always enjoy doing and chatting with everybody, some of whom I know quite well, and others who it's always a pleasure to meet. It's a shame we can't do this live as we always do, because I always have some fascinating chats with everybody, but we'll have to make do, as David said, in these strange times. And actually, before I start, I actually feel terrible sometimes when I chat to patients, because we're all focused on the virus, but then there are so many other things going around with all other patients that sort of get neglected around this time. And that makes it incredibly hard as a clinician to try and juggle the whole thing. But we are very much sort of open for business, at least from an advice point of view at St Mark's. So we're running as many telephone clinics as we can, and I'm starting to do more face-to-face. And we are starting to operate on patients who are urgent now at the local private hospital, which is considered COVID green. So I think for all of those reasons, things are slowly starting to come back to normal, and I hope that it continues in that trajectory rather than the other way around. Anyway, that's not the topic of my talk today. It's about innovations in pouch surgery, Chris wanted me to talk you through perhaps the journey of how everything evolved, and to look at some of the newer technologies that are available, and what are the benefits, disadvantages, and so on and so forth, just to give you an overview of how we are probably doing things, or how we are doing things now. But I find this is a slide given to me by John Nichols, and I find it a very poignant slide. And I think that sometimes we come to a point in life where we forget the past, and I keep reminding my clinician colleagues about this as well. And one of the important things is that ulcerative colitis was a disease that actually killed people. So these are data from across the London hospitals in the 1800s, before St. Mark's started treating ulcerative colitis, keeping in mind that we started as a hospital for anal fistulas. And you can see that actually a huge number of patients actually died in the early 1900s. And the reason I bring this up is because surgery sometimes is a lifesaver. And I know a lot of people have reluctance to have surgery, and I understand the reasons completely. But it can be a lifesaver even in this day and age. And the mortality, although it's very low now for ulcerative colitis, and that is because we intervene a little bit early, it's still not insignificant, because we shouldn't see people with ulcerative colitis die from ulcerative colitis. So I think that's just my starting slightly depressing slide. And I think one of the reasons why people find it very difficult is these are the stoma bags of the 1900s, and if you can imagine having to wear this thing and wander around, it can be quite difficult. And it's the fear of the permanent stoma that drove a lot of people away from wanting surgery at the time. And surgery came into being perhaps in the 1940s, 1950s, where people started realizing that actually doing a colectomy saved people's lives. But as going back to my previous slide, the whole idea was that you had a permanent stoma, and then you had to deal with these terrible stoma appliances at the time. And that wasn't necessarily pleasurable for the patient, and it was the quality of life that deterred people from actually wanting or needing wanting surgery. So in the 1940s and the 1950s, the idea of actually joining the ileum after removing the colon to the rectum started to become popular. But one of the big problems is that a lot of patients with colitis have colitis in the rectum. So if you actually leave the rectum behind and join the ileum to the rectum, you can have a failure rate of somewhere ranging from 10 to 50%. Now, like most things, a lot of these things are making a resurgence as well. In Sweden in particular, they perform much higher rates of what we call the ileorectal anastomosis, which is moving away from pouch but preserving the rectum. But when we analyzed, or when we looked at the data from Sweden and from us, we found out that they actually remove the colon much earlier in people than we do in the United Kingdom. And there are perhaps cultural reasons or various other reasons which we don't quite understand as to why that happens. So while this can be an option for people who have no disease in the rectum, I don't see that many patients that would fit the criteria, in my opinion, where this would be a suitable option. But certainly it is one of those things we do consider in certain circumstances. And the other thing to keep in mind, outside of the persisting proctitis or inflammation of the rectum is that some of these patients can also have cancer, and it means that if you're having surveillance for your ulcerative colitis, then that surveillance should not stop if you have an ileorectal anastomosis. So in the event that the ileorectal didn't work properly, there were various different ideas that came across in trying to bring the ileum, or the last bit of the small bowel, right down to the anus, so that you can go to the toilet without the need for a stoma. And the original was to just join the ileum straight to the anus. And as I sometimes say to patients when we talk about that, one of the big problems is that you don't have the reservoir, so you would end up going to the toilet so frequently that it will be not worth doing it. And then there were various permutations and combinations, like the one I have shown here, that came into being in terms of trying to create the reservoir. But the real starting point of all of this was this chap called Niels Koch from Sweden, who came up with an alternative to having an ileostomy that works constantly, to have what's called a continent ileostomy, meaning that the patient has control over when the ileostomy is empty. So it's a little bit like a J pouch, and it's quite complicated to do. That there are only a few people in the UK. I'd say a handful, one or two surgeons, mainly in Oxford, who can do it at the moment. I certainly don't have the experience, and there are patients who quite like it, but it has a lot of problems. The failure rates are very high, and the need for revisional surgery is very high, but it can be a suitable alternative in selected people whereby one can't have an ileoanal pouch. But the reason I put this up here was just to illustrate the point that this was perhaps the starting point to get Professor Nichols and Sir Alan Parkes to think about how to do a similar thing into the anus, and that was the birth of the modern day ileoanal pouch, as we call it, or the internal pouch. And so this was first written up in 1978 when they described their experience with it, and it was revolutionary at the time, and to a large extent it still is, because it offers a degree of quality of life to people where a permanent stoma is perhaps not a suitable option. And you can see that when they looked at their results about 2 years after they first introduced it, it was actually quite good. The only thing is, if I draw your attention to the bottom of the slide, most patients actually needed a catheter to empty. That was because the shape of the pouch, the first shape of the pouch that they actually used, was in the form of what we call an S pouch. And the problem with the S-shaped pouch was that a lot of people had problems actually emptying it spontaneously. And it is because of that, and the high need for catheter usage, that the shape of the pouch gradually changed to what we currently commonly perform, and that is the J pouch. So the next thing I really like to say is that if you look at this graph here, what this says is that the more pouches you do, the less failures you get. And perhaps it's not necessarily technical, and this is one of the things that those of us who perform a lot of pouch surgery try to make a big deal about, because and I always say to patients, I encourage you all to ask your surgeon, and if I'm your surgeon, ask me as well. And I get asked all the time, how many do you do and what are your results? Because it varies from surgeon to surgeon. And I do about 20 to 30 pouches depending on the year, per year. And that might seem like a very small volume, but that's actually one of the largest volumes in England. And so therefore, you can see that the actual number created per year in England, for example, is only 300. So it's not a large volume operation. So if your surgeons are not doing that many, then then the results of the pouch are not very good, because you don't have the experience to work it out and say, you know, if the pouch lies like this, or how do we not twist the pouch when we're doing it? And there are so many technical steps that one has to go through, that if you don't do it that often, it doesn't become very good. So anybody who's thinking about having a pouch, always ask your surgeon how many you do. And there are quite a few centers, not just us at St. Mark's, around the country that actually have a high enough volume. And we say that if a surgeon's doing somewhere around 10 per year, that's a reasonable number. And this is just to highlight the same point, is that when we actually looked at the number of centers around the country that are doing pouches, and you average it out, each center's probably doing 4 per year. And if there are 2 surgeons in a unit, and that's not necessarily true, then they're doing about 2 per year, which means that it's actually a very low number in some centers. Because when we looked at the recent pouch audit, which was published last year or the year before, there were some places where a pouch was done once every 2 or 3 years. And then the problem, of course, is the support as well. I know within this Zoom call, we have 2 latest additions to the pouch team, Petya and Riley. And one of the good things about St. Mark's is that it's not just me alone as a surgeon, it's the support that all of you as patients get from our pouch nurses, who are hugely more knowledgeable about the after the pouch than even I am. And I refer back to them quite frequently to actually get advice on how to deal with certain situations. So I think the whole package is what's important, because, as I always say to patients, having a pouch is a quality of life operation, because you can choose between having a permanent stoma or choose between having a pouch. The life-saving part is removing the colon. Having the pouch is for your quality of life. And therefore, it's our job to make sure that we can tweak it as best we can to work with an individual's quality of life. And therefore, having that support is absolutely vital. And you can see that if you have over the years a larger number of pouches, then the chance of the pouch surviving within the hands of those surgeons, or within the hands of those institutions, I would say, is much greater. Now, in the past, these were all done as open surgery, and for a lot of patients, the big issue was not so much the pouch function as a result of open surgery, but there were 2 main issues that came about. The risk of needing admissions to hospital for adhesions was one of them. The ability to get pregnant, or the possibility of not being able to get pregnant was another one. And also, and this is a little bit more my observation rather than anything that has come from the literature, but I find that especially in women, the rate of rectovaginal fistulas, or fistulas between the pouch and and the vagina were a little bit higher in the open era, maybe because the vision was not that great. So this is where when laparoscopy, or as commonly called keyhole surgery, came into being, this became quite quickly adopted to pouch surgery. And the advantages are stated: there's less scarring, less pain, the cosmetic results better, you stay less in hospital, certainly less adhesional admissions, and from the surgeon, better vision, and for the patient, again, probably less sexual dysfunction as well. And this is what a pouch looks like. And I've left the gory pictures to a minimal, because one time actually it wasn't me, but one of my colleagues put some gory pictures, and it distressed some people. But this is just what the pouch looks like as it's joined to the anus, and you can see that we are looking at it from a laparoscopic view, and you get a very good view. And in particular, just trying to get my pointer up here, is where the vagina will be, and it's important to keep that well away from the pouch. And you can actually get a very good cosmetic result in terms of having very, very minimal scarring. And that's particularly important for people as well, because some of the scars, the longer the scars, the more risk of wound infections. And if you have a wound infection and you're particularly a young person, that the risk of having a not so nice scar is quite high. Now, one of the big things to think about is that we traditionally do the pouch in 3 stages. So the first stage involves removing the colon but leaving the rectum behind, and at that stage a patient has an ileostomy. And I often say to people that the reason we do that is because most people who need a colectomy have some form of are currently on steroids or some sort of biologic agent, and are relatively immune suppressed. So if you do a complicated operation like a pouch at the time that you're on steroids or on complicated immunosuppressive treatment, the risk of that pouch, the joint leaking, is very much higher. And if the joint leaks, and I'll show you in a little bit, the risk of failure is also higher. So that's the reason why we do the colectomy first and then come back when all the medications are off at a later stage. And actually that's the time an individual feels the best, because when you come to the decision for having surgery, you feel quite sick and quite ill. And then the moment the colon is removed and you're not taking medication anymore, you actually feel much, much better. And anything after that is not as much additive as this procedure. But it also gives the individual an opportunity to actually appreciate what life is like with a stoma. And there are a number of patients who actually say, you know what, that my quality of life was so bad before the colitis, I now have this, I don't really want to have another operation, I'm happy with the stoma. And it's a very individual decision. And I think more frequently people are feeling comfortable with the idea of having a stoma. And I think a lot of that has to do with also the way things have gone in social media in terms of positive approach to having a stoma as well. I'll just skip that. So as I said before, I think there's a significant reduction in adhesion-related admissions, and I think that can definitely be attributed to having keyhole surgery as well. And also this issue around what we call fecundity, or the ability to get pregnant. And as I explained to patients, one of the problems is that adhesions are not just about developing small bowel obstructions. Adhesions also happen around the ovaries and the tubes, and they're no longer free floating enough for conception to occur. And therefore, what used to happen, and a lot of the time people used to say that if you have a pouch, and or if you have a colectomy, it is best to have your family before you have the pouch, because your chance of getting pregnant decreases after you have a pouch. But, and you can see these are very old data, and this is what it shows. But what we have seen now is that you don't get adhesions to the same degree as you do with laparoscopic surgery. And therefore it's the same applies to the pelvis, and therefore the rate actually sits roughly here. So there is no difference. And this I think is one of the major advantages for women in terms of having the pouch surgery now, is that we don't have to advise people to wait for their pouch till after they have completed their family. Now, there are, as I said to you, we traditionally used to do the pouch in 3 stages, and the main reason for the 3rd stage, which was where we create the pouch and then give someone an ileostomy, is that if you have a leak after the operation where the joint doesn't quite hold together, that ileostomy is said to protect that area while it's healing, and it can be dealt with. But as time progressed, the next innovation as such in terms of pouch surgery was this ability to actually remove the rectum from the bottom, or we call transanal mesorectal excision, or removing of the rectum. It's actually quite a difficult procedure, but again, was something that I did with some of my colleagues in Milan and in Amsterdam and in Belgium. And the 4 of us got together, and we sort of developed a working group of how to actually remove the rectum and create the pouch in a much more controlled way than what was done before. And one of the major advantages that we saw was that we were able to join the pouch much lower. That means that the amount of rectum that we leave behind is much less, so we can control it. Now, why is this important? For those people who get counseled about having a pouch, we often talk about things called pouchitis and colitis. Pouchitis is when you get an inflammation within the pouch, but colitis is where you get inflammation within that last bit of rectum that we leave behind. And the reason we leave that behind is because that allows people to actually go through the night, or at least minimizes the risk of leakage, particularly during the day and at night. Whereas if you remove all of the rectum, then you can get some seepage. So in terms of that's where the signaling mechanism is for telling your brain when there is something there. And so we leave that cuff behind. The more cuff you leave behind, the more chance of colitis you get, and that's the major issue. So by actually being able to remove the rectum from the bottom, we can decide exactly where to divide it, and therefore we can really minimize the cuff to that which is needed for continence, but not to give problems. But we also changed the way we did the join, and based on that, at least certainly in my hands, I found that the amount of leaks reduced significantly. And as a result, we are also able to now add what's called the single port, which is doing the surgery through the ileostomy site, which we can do for the colectomy as well, which means that it's almost scarless surgery. And at the end of the operation, the only scar a person has once the ileostomy reversed is where the ileostomy is. And that's been, and so when we combine the two, that's been one of the big advantages, I think, in pouch surgery in recent times. And we recently combined all our data from the 4 institutions and found out that the complication rate from the surgery is much less, and people's quality of life is no different to having it done with the laparoscopic, although in certain physical functioning as well as the risk of colitis was reduced in those patients who had it this way. So this has now been my standard approach to most patients who need an ileoanal pouch, and even those patients who have had open surgery to have their colectomy somewhere else. We can still do most of the operation by this approach, depending on how much adhesions are there within the abdomen. And this is for sort of what the bottom looks like. So we're able to see from the bottom as well as from the top. So as I said to you before, the consequences of having a leak. Now, this is a risk prediction score of pouch failure, and you can see that if you have an anastomotic leak and pelvic sepsis as a result of that leak, over the longer period, your risk of pouch failure can be about 17% or so. But if you don't have a leak, we can drop that down to about 7%, and that's significant. So a leak is sort of one of my most dreaded issues, and it's the one I like to try and minimize, reduce, and really watch as closely as possible. So the picture on the right is where the way we do the join now, and you can see that it's not as you don't have these little edges that come out, and therefore we find that it's a much more robust join, and that's probably the reason why we see that the leak rate's reduced. But together, and you can see the quality of life improves over time, and it works out quite well for these patients. The other innovation that comes with this type of join is that we've been able to do most of these procedures now without the need for a covering stoma. So we've moved away from the 3-stage approach to now a 2-stage approach, so that the patient has a colectomy first and then subsequently has their pouch created, and we don't do a stoma unless there is something during the operation that makes me feel that the joint is at risk, in which case we do. And and the approach we've taken is that we watch those patients very carefully, and we're able to pick up the leaks early, meaning that we would do a CT scan if there's any suspicion, and then within the first 3 to 5 days, we would take someone back to the operating theater and give them an ileostomy. So if the leak rate is about 8%, that means that for 100 patients who have pouches, only 8 of them would, a little bit more, because some of them we speculatively give a stoma to, but about 8 or 10 patients will need that 3rd stage. And that means that 90 patients don't need that 3rd stage, and that's been a major innovation and a good thing. One of the other advantages is there's this concept of having delayed leaks. So even though people have an ileostomy, we see a lot of patients who come through with a diagnosis of pouchitis, but when we do an MRI, you can see that clearly the pouch has a leak that has been unrecognized, and they could be so tiny that even if we check the joint before we close the ileostomy, you might miss a small leak, and so doing it this way means that we can reduce those delayed leaks as well. So I'm going to conclude there, so we have plenty of time to talk about things. So the one thing I wanted to mention, which I haven't got a slide for, but it's about the robot. Everyone gets very excited about the concept of having a robot, we also have one at St. Mark's, which I think is gathering dust at the moment because of the COVID more than anything else. It's certainly a newer tool and exciting because of its name more than anything else, but it's just another way of doing keyhole surgery. So it has certain advantages in terms of good vision, for example, but in my experience, it doesn't add a huge amount more to the concept, to the overall concept. But if someone is well trained in it, it is a very good technique to use. I'm certainly not well trained in it, but I don't feel that in my practice, for example, it adds a huge amount. So I think it's very much operator dependent, but I don't think that it's a technology that is going to drive better pouch surgery. It is just, if someone is a good trained robotic surgeon and they do lots of pouches, then they will be a good surgeon to have a pouch with, and it's not necessarily the technique that has to drive what one does. And that sort of takes me into my conclusion quite nicely, because I think the key is that we should be doing more by keyhole methods, whether it's a robot or standard keyhole surgery. You have to have them done in centers with a high volume. And I think the ultimate aim of the surgeon has to be to realize that we want to try and reduce as many technical issues as possible to reduce the failure rates related to technical problems. And as a result, to improve people's quality of life, because as I say to everyone, this part of the operation, the pouch part, is not the life-saving part. That is the improving quality of life part. So thank you very much for having me, and I'll take any questions as they come.
Well, thank you very much indeed, Janindra. That was a fascinating run-through, race-through of the innovations that are happening in pouch surgery. And on behalf of the audience, I'd like to thank you for that. Ladies and gentlemen, just to remind you of the question function, if you squiggle on your pointer on the screen, up comes the bar at the bottom. You've got a chat button right in the middle. You click on that chat button, you can type in any questions that you have or may have for Janindra, and I'll put them to him on your behalf. So just while we're waiting for those to flood in, Janindra, I've got a few there. And just to also emphasize that point, you know, Janindra mentioned he does 20 to 30 operations a year. This is one of the top pouch surgeons in the country, if not in Europe, if not in the world, and he's right here for us. So a great opportunity to ask all your pouch-related questions. And just lastly, I should have mentioned this at the start, but every one of the audience, I think, are either pouchies, potential pouchies, or indeed friends or families of pouchies. And that includes Red Lion Group members, members from the sister charity, our sister charity, the Kangaroo Club in Oxford, and also from the Joe Pouch UK specific Facebook group. So welcome to you all. I should have mentioned that at the start. Can I ask you, Janindra, are the number of pouch operations decreasing in the UK? And if so, what are your thoughts on why that's happening?
So that's a really good question. I think they're relatively static, but if I go back to the Sweden example, if someone has a colectomy in Sweden, you have about a 50% chance of having a restorative procedure, meaning either an ileorectal or a pouch. In the, I'll take guesses as to how much you think the conversion rate is in England.
The conversion rate in terms of?
From a subtotal colectomy to a pouch or an ileorectal.
What's the? Well, I thought it's pretty high.
It's 30% actually.
Wow.
So 70% of patients after having a subtotal colectomy do not progress beyond that point. And that actually shocked me, as I'm sure it would shock everybody here. And I don't know the answer to why that is, but I can hazard a guess. And I think part of the problem boils down to the fact that in those centers that have very low volumes, the outcome has been so bad that people get discouraged from having any surgery or being referred to a center with a high volume.
Yeah.
And I think that there is an open discouragement, because I've had a few patients who come and say, oh, well, you know, sometimes even up to 10 years after subtotal colectomy, and say, you know, I didn't know I could have another procedure. And I say, well, I don't see why not. And that leads on to the next thing that a lot of people say, well, how long can I wait? Is there a waiting time? And in all honesty, I don't think there is. I don't think there is a waiting time. If you want to wait 10 years, wait 10 years.
Can I come in on that, Scary speaking? Because when I had my total colectomy over 30 years ago now, 35 years ago, I was in that situation you described. My quality of life had improved so much that I wasn't in any hurry to have the pouch made. And I actually was meant to go back in 6 months later, but declined. I was told that I would at some stage need, if I decided not to proceed with the pouch, I would still need major surgery at some stage to remove the rectum. And I was given a time scale of about 5 years. I think maybe at the time they thought there may be issues with keeping the rectum. So I actually lived with my ileostomy for about 3 years. Decided that if I had to have major surgery anyway, then I may as well go ahead and have the pouch, which I'm glad I did. That's 33 years ago now, and that's how long I've had my pouch for. But the quality of life thing, I certainly got that, because after the colectomy, I was enjoying myself for the first time in a long time. But I was given the suggestion that after about 5 years, it would be wise to remove the rectal stump, which had been left behind. So maybe the story has changed on that slightly.
So I think it's got to do with surveillance. So if you leave the rectal stump in for a long time and don't survey it, then there is a cancer risk. And I think that's probably the reason for that advice. But if you're within a surveillance program and have someone looks in with endoscopy every year at that, and that's done religiously, then there's no reason why you can't keep it longer.
Okay, we've had a raft of questions coming in, so let's try and get through as many of these as we can. Several relating to pouchitis and cuffitis, Janindra.
Okay.
What's the causes, and is there anything that people can do to reduce the risks of cuffitis and pouchitis?
The cause is unknown for the most part. There are various theories around it, but I think just if you sort of extrapolate, or if you look at those patients that have pouchitis in particular, if you've had your pouch for adenomatous polyposis or FAP, as opposed to ulcerative colitis, the rate of pouchitis differs significantly. So those people with ulcerative colitis have a much higher risk of pouchitis than those people with FAP.
Yeah.
It's not to say you don't get a pouchitis in FAP, it's just much lower. And so we think that that has to be some way of explaining the fact that there may be an autoimmune issue, because ulcerative colitis in its sense is an autoimmune thing, and it's just the progression of it. But the treatment's widely different, because we tend to give antibiotics to treat pouchitis, which then leads me to my second hypothesis, which is that there's going to be something in the bacterial concentration in the ileum that we create the pouch with that perhaps drives that inflammation.
Yeah.
So, for example, when you have your colon in circuit, there's no bacteria in your ileum. So when you create a pouch, that changes a little bit when you have an ileostomy. But when you create a pouch, that ileum has to now adapt to being a reservoir. It also has to adapt to the bacterial environment. So there's a whole host of new things that it's got to learn about that might then subsequently drive inflammation. And we don't know what drives the inflammation in ulcerative colitis, for example. And therefore, that makes it even difficult. So it's a hard question to answer. Cophitis is just inflammation of the little bit of rectum that we leave behind. And so I think that's just an extension of ulcerative colitis.
Yeah, thanks for that. There's questions coming in all the time, but one of the another theme here is COVID and the susceptibility of people with pouches, or indeed on anti-autoimmune medication with regard to the virus. Any comments on that?
Yeah, so we don't have any evidence one way or the other, but I think everyone on biologic agents or that sort of immune suppression medication have been asked to shield, and I think quite rightly so. My advice to those people who have a pouch but are not on any medication has been that I think the risk is as much as it is with the normal population, provided you don't have other comorbidities. I don't think the pouch per se is going to increase your risk of not contracting the virus, but getting very sick from the virus.
Yeah, indeed. I think just...
I think the short answer is I don't know.
Well, yeah, that's very honest. Let me help you out. The Ileostomy Association and Crohn's and Colitis UK have very useful flow charts for depicting or describing the risk that people have, particularly if you're on autoimmune medication. And I would refer you to those references in the first instance. They're really very good, and they give a very succinct answer to that. Let's stay on the problems. If people have a pouch surgery coming up, or indeed they have problems with their pouches that require a referral to St Mark's. In light of the current COVID restrictions, what's the best way or the fastest way for them to be seen? Is there a consideration of them looking privately? Is that going to get them quicker treatment? I'm asking on behalf of other people who've asked questions on the link here.
So I think privately NHS it's pretty much a little bit the same at the moment. Everything's in a weird state of limbo. But as I said at the start, I think we're still trying to do our best to run business as usual, because I personally feel that this is not an anti-lockdown talk in any way, but I personally feel that the virus is the virus, but everybody else can't be on hold just because of the virus. So we have a responsibility to provide best possible care under the circumstances, which means that you do it a little bit not as well as you do it normally, but try and do it as best as you can. So with that in mind, I would say that I'm running telephone clinics, for example, and people are still being referred through various channels, and we try and address those as best as possible. Our pouch nurses have the pouch email, the helpline email, telephone, etc., which is being answered as best they can. So in those terms, those services are still running and are available.
So I'm going to pin you down here because I know it's a specific interest for a lot of people on the call, but in terms of arranging for a referral, the best way is via healthcare providers referring GPs or specialists referring via what? Is there a website, or is there the pouch nurses?
I think in this at this time it might be safest going by the pouch nurses. They'll probably kill me for the inundation of emails, but
okay.
At least we know it'll get looked at.
Oh, all right, thank you very much. So more questions all the time. So a specific question, very specific question on the use of antibiotics. And if someone has pouchitis and takes antibiotics to relieve the symptoms, is it okay to stay on them continually, even when your symptoms cease?
Okay, so good question, and I think this is where it has to sort of, in a sense, be supervised. So we have an algorithm, and it usually actually starts with the pouch nurses, and it's only when things get difficult that we intervene. But usually you have to have pouchitis diagnosed by having a pouchoscopy and biopsies, because one of the big problems, as I said to you before, was that there are people who have this label called pouchitis, and they haven't gone through the whole investigation gamut, and suddenly you find that it's actually, there is a lot of sepsis outside the pouch because there's been a long-standing leak. So there are, that's just one example, but it's just to highlight that it's got to go through a process before you label something pouchitis. And we usually like biopsies confirming that, at least in the first instance. And usually in most situations, and I'm talking about 80% of the situations, a 2-week course of antibiotics would be useful, and that's all that's needed, and then it should really stop, because what you don't want to do is stay on those antibiotics if you don't need them. If you've got recurrent pouchitis, again, you can circulate through the antibiotics, and it depends on how frequently the recurrences happen. So, you know, if it's once a year, then you do your 2-week course once a year. But if it's more frequent, then we may have to have a different strategy. And then we tend to do things like circle antibiotics, rotate them around, sometimes keep in longer. And some people do stay on a long-term low-dose antibiotics because it seems to make their pouch work well.
Yeah. Excellent answer. Thank you very much indeed. How does the age of the patient affect the outcomes for pouch surgery? Is it better to be young, or is it better to be old?
I don't think it matters. I think it matters as to how fit one is for the surgery, because it's big surgery. And I think there was a time again when people felt that if you were over the age of 60, you shouldn't have a pouch. But we recently combined data from a lot of European centers and looked at it, and we didn't see that there was a big issue with even creating a pouch in people much older than 60. So I've sort of taken away the age cutoff and have a discussion. The only caveat to that is in postmenopausal women, we would look at the sphincter function, because especially if they've had a few vaginal deliveries, then it's important to work out what's happening with the sphincters, because the risk of incontinence can be higher. So, and then we can have a chat based on that.
Okay, excellent. Thank you indeed. I had an excellent question submitted earlier, which, in light of the topic of the talk, which is when pouches stop functioning, are there any new procedures that would avoid a permanent stoma?
The short answer is no, because a lot will depend on what stops the pouch from not working properly.
Mm-hmm.
So if there are certain circumstances where a pouch can be redone, and that they're sort of getting more and more limited in terms of because if sepsis is the reason for the pouch failing, then the redo can also fail.
Yeah.
The risk of the redo pouch failing is quite high. Otherwise, there isn't anything massively novel to actually save the pouch at this point, except for going through various ways of trying to improve the quality of life. And this is again, different people have different views as to when a pouch will fail for each individual. Some people very early on, some people much later. And if you put all people in a room together and they share their experiences, you'll find that different people have suffered a lot, but they don't see that as suffering because the alternative is not an acceptable alternative.
Some more questions flooding in. Time for a couple more, I think. Just bear with me. Oh yeah, if you do have a pouch failure and you revert back to a stoma, what are the chief complications of that?
So I think the first thing and the most important thing to say is that stoma is never going to be the same as the stoma you have soon after the colectomy, because it's a stoma that's much higher up in the small bowel. Therefore, it is going to be much more high output. And so that's one of the things to worry about, because or think about, because that's where things like dietary changes are very important in terms of massively reducing the amount of fiber one takes, increasing the starch, so on and so forth. And there's also the element of trying to prevent dehydration as much as possible. And I think a lot of people give very bad advice in terms of managing high output stomas, as in, oh, you've lost a lot, you should drink more. And I think that's one of the worst things you can tell anybody with a high output stoma, because the more water you drink, the more you put out, and it becomes a massively vicious cycle. Because what you really need is salt.
Right. Excellent. Okay, thank you. We're kind of drawing to a close now, but there is one theme that we haven't touched on yet, which we've had a few questions on. That's the use of catheters. Catheters to empty the pouch in patients who require that. One very specific question from Linda: would you recommend a Medina catheter or Cufora? With apologies if I've pronounced that wrong.
So I think Cufora is one of those preparations that we prescribe a lot for people who are constipated, who have a colon. So it's more like an irrigation system, and a little bit will depend. A little bit will depend very much on the thickness of the output, and it's almost very rare for the thickness to be so solid that you actually need something like the Cufora to liquefy it to be able to come out. So our experience is that more often than not, we would recommend the Medina.
Okay, all right, great. Okay, that's about to cause a big argument, but listen, we're short of time.
If the Kafara works, it works. I'm not. Now, pouch nurses will be better at answering that. Maybe that will. When you have them on, you can ask the same question, and they'll shoot me.
Very good. Listen, we must draw things to a close because time has caught up with us. There were many other questions coming in, but unfortunately, we won't have time for them. I'd just like to close with a couple of comments. The first was a big vote of admiration for your bookshelf behind you.
Oh, thank you.
People are very like that very much. The second is we actually have Zara Perry Woodford in the audience, and she's confirmed that the pouch nurses won't kill you for mentioning that they are the first point of contact. So that's good to know. The last point,
Zara won't kill me, then I'm very safe.
the last point, I think you just without causing you any embarrassment, is a comment that came in. It wasn't a question, but it came in from one of the audience. Janindra is one of the most kindest, caring, empathetic and special people I've met. He saved my life twice following sepsis and perforations. I've had 3 stomas now, all resected. I am genuinely in awe of Janindra. And on behalf of everybody in the audience, I think that sums up one person's experience, but certainly a common sentiment, I think. I think you're pioneering fantastic developments in pouch surgery, which are benefiting us all, and indeed future pouch patients. And on behalf of everybody, thank you for today. Thank you for your presentation. And do please continue your great work.
And thank you very much for having me, and it's been a great honor. Thank
you. And just last to say, there are further webinars planned. In fact, we have Zara herself on the 11th of June. And before that, we have Professor Yoram Inspector on the 4th of June. For everyone listening, if you'd like to look on the Redline Group website for more details, we'd be delighted to have you join those future webinars. Last of all, thanks again to Janindra. Have a great day and keep safe, everybody.
Thank you very much.
Bye.
Thank you.